This chapter, I know we were just going to talk about sympathy versus empathy, but I do want to go over just a few things on here that aren't going to necessarily be on your test, just the area about sympathy and empathy. But I did want to go over a few things that will help you in the clinical setting. I know some of you have already been to mental health, but this will also help y'all who are still going to Greenfield or some of the other facilities, and even help you with your other patients as well, because remember, we do still have mental health patients on our medical floors. This is when you have this relationship, when you approach one another, this is the first connection where an understanding is going to be recognized that the nurse should be safe, confidential, reliable, and consistent. So the relationship has a set, clear, and very appropriate boundaries, and those need to be set in the very beginning. Patients are more engaged if the clinician or the nurse interacts and addresses their concerns, shows them respect, and it makes them a partner in their decision making, and is usually very straightforward in their communication. The nurse needs to consistently focus on the patient's problems and their needs. And boundaries are usually defined under the therapeutic relationship and should not fall into any kind of social relationship. And there's a fine line that we have to remember that is there. Remember, the needs of the patient should always be met and not the needs of the nurse. Necessary behaviors for the nurse. For accountability, we're responsible for our own conduct and the consequences of our own behaviors. Our interest of the patient should be always there and not for ourselves. You are their advocate. Under clinical competence, being knowledgeable and keeping up with evidence-based practice. For delaying judgment, you want to refrain from judging and avoid transferring your beliefs and values onto that patient. And then under supervision, if this is working with a team or a clinician who oversees your growth. When we think about some of the boundaries, your physical boundaries, this includes like the environment and the place and where you're meeting and where you're having conversations. The contract, this is setting, this is the time limit, this is the time we're meeting, here are our roles, and to let them know that there is confidentiality during those meetings. So everything they say is in confidence. Personal space, this is that physical space and emotional space. Someone who's very aggressive, I'm not going to sit very close to them. I'm going to make sure I have the appropriate distance. Sometimes boundaries can be blurred, so making sure that there's a safe place to explore feelings and treatment issues. A nurse should not be searching for attention, affection, or emotional support at the expense of their patient. And boundaries are set to protect your patient. So I would like for you to look on page 134, table 8-1 for some examples. You may remember this from an earlier PowerPoint. One of those is transference, where the patient unconsciously and inappropriately are going to displace onto the nurse feelings and behavior related to significant figures in that person's life or in their past. So this can be a positive or a negative experience. It is the negative that is the greater concern, because they could become aggressive towards you. When it's countertransference, this is where the nurse displaces her or his feelings related to people in their past onto the patient. So this can stall This can stall the relationship, and it can actually disempower the patient by seeing them as an extension of ourselves and not as an individual. So maybe they remind you of, Aunt Susie, who was always very condescending and not very nice to everybody in the family, and so they remind you of that person, so you kind of treat them the way you feel about Aunt Susie instead of actually seeing them and their issues. Over-identification is common. Also, so the nurse might have difficulty recognizing or seeing things in a more objective manner, a patient's problem that is actually similar to their own, and so they can't separate that and what they dealt with or how they dealt with it in the end. So there's a good example on page 134 through 135 and table 8-2. Pablo has a model, and it talks about the orientation, working, and termination phase. But I do want to just real quickly say that there is a pre-orientation phase, and this is before the meeting, and this is where you're going over everything and preparing to meet with this patient. You're getting some history from some charts and getting everything together. The orientation phase, this can extend actually past the first few meetings, so it doesn't have to be the initial meeting. But it's actually the first interview that takes place. There's some bullets on page 139, and this is where you're going to establish a rapport with your patient. Parameters are going to be set about the relationship. Again, you're going to have a contract, whether it's formal or informal, and that needs to be agreed upon. The patient is informed about confidentiality issues and when that confidentiality has to be broken. And remember, that's when there is risk of harm or injury or death towards themselves or someone else. And then the terms of the termination are going to be introduced. So telling them we will end this relationship or this phase once you have met certain goals. During the working phase, this is a busy stage, as you can see on the slide. And this is really identifying, exploring problems in that patient's life. What are their coping methods and goals? So we're going to discuss those and explore those. And then unconscious motivations that might be going on, and any assumptions that may have been identified during these meetings. Then you get to the termination phase, as you see here, and this is either the discharge or the end of the student rotation. So there is a task for termination, and there's some bullets on page 141 you can review, and needs that need to be addressed. These are also some bullets on page 141 as well. Here's some factors that can help you with that nurse-patient relationship. So with consistency, you want the same nurse routine. It needs to be frequent and regular interactions. You need to make sure you have a good format and a location. The nurse should be congruent in her communication or his communication. As far as pacing, let this patient set the pace and adjust to moods that are going on, because some of them will be quite moody. Listening, this is very key. Let them talk when it's needed. And silence is fine. Sometimes we feel like we need to fill in that hole when there's some silence there, but sometimes it's a time of reflection. So it's okay for there to be some silence. As far as initial impressions, make sure that it's positive and be considerate, and this can actually lead you to progress in that relationship. Keep a balance. Don't be too strict or too lenient. Show caring towards patients and allow for them to have comfort. Also, positive factors are trust and active participation on the part of the patient. What can lead to negative relationship is inconsistency and unavailability on the part of the nurse or on both parties. On this slide, you'll see there is a YouTube. You can probably pull it up better on your other slide that you use for notes. But it's a cute little cartoon animation, and the lady is talking about sympathy versus empathy. And I thought it really helped explain, and so it's really neat. But one of the things that we have to think about when we're promoting growth with our patient is, empathy and not sympathy. And really, empathy is walking a mile in someone else's shoes. When you think about sympathy, this is, I'm sorry that your feet hurt. So empathy is walking a mile in someone else's shoes. Sympathy is sorry that their feet hurt. So think about that. One of the things you want to do also to promote this growth is be aware of your own feelings and being able to communicate them when it's appropriate to help build that trust. You don't have to let them know everything and all your dirty laundry. But it needs to be done by listening and communicating clearly with your patient. Understanding feelings and that are experienced by someone else. This does not mean you condone or approve of a patient's actions, but that you are being non-judgmental and non-critical of their choices versus feeling the feelings of others. So objectivity is sometimes lost when you feel sympathy for that patient and you use the ability to help them solve their problems. So there's some examples on page 143 that you can look at. Another thing you need to do is make sure that you show respect and that the patient is worthy of care and has a potential for achievements. You need to have an attitude that you are willing to work with them, and then that's going to be the foundation of your interview. Your actions is that you need to be more attending. That means listening and being with the patient and not being judgmental and not going off in la-la land thinking of something else or doing paperwork while they're just opening up to you. And the other thing we want to do is we want to help them perform at their most optimal level. So on page 144, they do give you some examples. Lastly, here's another little link, and it's an example of some students giving poor communication and some things that you want to make sure that you don't do. All right, that's all I have, and I'll see y'all in class.